Okay, so we had a good bit of discussion about Cardioband in the mitral session this morning. We'll show you what it looks like. Slides up, annular reduction with Cardioband. Skip disclosure slide, but so on the left, obviously the surgery version of this, and this is a transcatheter version of the mitral repair with Cardioband on the right, and we'll look through some pictures of this. But fundamentally, this is done transeptally, and then insertion of this system to deploy a flexible partial ring, if you will, around the posterior leaflet, and then adjusting it by turning the screws to pull the band together. And it's important because when you see how this is laid down, it's important to cross in the right place to give yourself plenty of height to move around the entire annulus on the posterior rim. And you can just see from the puncture sites, you obviously want to get superior enough that you can then approach it posteriorly going across and make your punctures in the right way. So here's a baseline of the mitral valve. And then this is the fluoroscopy look of these screws that are being implanted through the cloth piece that is attached to the metal wire that it runs along the cloth that can be tightened to cinch it down. You can see in the bottom right-hand side that after they've been deployed, we get 16 screws through this cloth piece, and then essentially with a long screwdriver, we tighten this down, watching under echo guidance the aspect of how much MR reduction you get. We started this in pigs in the countryside in Piemonte, and we were using ice at the time, and the fact is that we really didn't have any good imaging in pigs, and it was hard to see. It turns out once we got to humans, it was easier to see this, and you'll see some of the brilliant 3D imaging that allows you to follow this along with echo, much more so than fluoro. And you can see the piece of it where the hardest part is to get the first screw down, and after that you just kind of follow the path along because it guides you, and you're trying to deploy a screw about every 8 millimeters, generally requiring about 16 screws. And it does take several minutes to get each screw, so it's a little bit of a tedious process right now, but I think that will continue to come down. You can see the Cardioband implant there, going from 10:30 or 11 o'clock all the way around to 7 o'clock around the posterior leaflet. Here's severe MR prior to cinching. After cinching, this is a Dr. Vannon echo that it just tells you how much MR does the interventionist want to hear. Some, none, mild, not moderate. And you'll see the results in just a minute. I'll show you the 61 patients. But if you look across this, you can see from baseline to laying the device down with the screws and then cinching it up. And this is in the article from our fellow that we had from Tommy Walther for your Manny Arsalan, and you'll see the report of that. Same thing, this is now the images across the top of 3D with the left-hand side pre-cinching, right-hand side cinched down, and then the reconstruction of what that looks like as you cinch that up in what Dr. Reardon was talking about this morning. Then again, same thing. You can see that the AP diameters here come down from over 3.5 to almost 3. You'll see some data later that shows fundamentally this comes down from over 3, probably 3.7 range to just a little over 2.5 in the AP diameter. In the anterolateral diameter, again, you can see we can drop down from 4 to 3 as this tightens up. And we narrow the aortic mitral angle as a result of that. This is sending Rob Smith and Paul Graburn to Hamburg with Karl-Heinz Cook last October as we got started, headed for the U.S. pivotal trial. This is the first report from Paul Graburn and Monty, basically just showing that the three-dimensional geometry of the mitral annulus could be reduced and could be successfully changed with this device. And here is the article out of Francesco and 11 institutions where these 61 patients were done You can see the baseline characteristics and demographics, but fundamentally 60-40 ischemic to non-ischemic, 60 LV diastolic diameters, and reasonably bad LVs down in the low 30s on average. Of the patients, 2 deaths. This is 30-day mortality of a little over 3%, and then 1 stroke, 1 elective operation, 1 myocardial infarction, and 1 tamponade. Again, this shows you the curves, the septolateral decrease, 30% reduction, 3.7 to 2.6, and you can see that after discharge, this is maintained out to 2 years now for these patients. And then the reduction in mitral regurgitation, all significant to 0.001, both at discharge, 1 month and 6 months. New York Heart Association class, same thing, 0.001, maintained to 6 months, and less than or equal to 2% MR, 24 months by 92% of the patients out at that part. So 12 months later, functional improvement, quality of life scores, 6-minute walk test, New York Heart Association, all significant to 0.01. 24 months, same thing, all still significant out to 24 months except for the 6-minute walk. So again, in the discussion we had today, don't forget the caveats that the surgeons have known. If you don't replace the valves, repairs will also have recurrence and can still come back with leaks. But this, at least at this point, looks like a very viable opportunity to repair some mitral valves from a transcatheter approach, especially on the venous side. And the protocol for the U.S. pivotal trial is in place. We have IRB approval and are expecting our site visit. I think everybody who's participating in this trial is expecting a site visit sometime this month. Thank you.
So, David, I'm curious, could you ponder why you think there's a difference between the outcomes with the CTSN trial, where you can argue there are a lot of very experienced mitral valve surgeons, versus the outcomes with the Cardioband? Any thoughts? Are the patients the same, or what's the difference that you're seeing?
So I'm going to start with the idea that there are 3 kinds of lies: white lies, and statistics. And so whether you start with patient selection, how many patients, whether you start with small numbers, how far out we go. I got to show a few cute curves and graphs and some other things, and everybody has the ability to present a lot of things in a good light. I think we're seeing some of that. I think, surgeons, as you well know, great surgeons have great repair. We could put Steve Bowling up here and listen to the diatribe for a while. But I think the fundamental issue, especially as you look at ischemic and non-ischemic, if you repair these things, I think, people live and change and physiologically move. And I think regardless of how it happens, it's going to leak. And I think the same thing is going to turn out to be true of Cardioband. But fundamentally, it's the old idea of, well, we should preserve your native anatomy. We should repair things. Do you have 100% repair in your institution? What are your core values? You can't go replacing valves. They get to look at it every month. So, I think we're headed to the same place. Anson?
Yeah, well, I think that's a misconception out there that, replacement is no good. But you have to think about when surgeons say that they want to repair the valve, they're repairing degenerative disease, not functional.
Right.
So
at least now it's become acceptable to replace the valves,
right,
due to a number of trials now.
That's right. So, and then in those patients, you should be replacing it. And absolutely, if you are actually using a partial band, fixing functional mitral regurg, it guarantees they're going to recur. None of the surgeon even repairing it using functional mitral regurg.
Well, and I think Gaurav, and you've hit on the whole aspect of everything went to, you've got to talk about repair, and replacement got a bad name regardless of what it is. Let's not forget it is expansion, it is functional, it's dilating the annulus, it's whatever you want it to do. So we can talk about that till the cows come home, but especially when you move to the transcatheter venue and you see people dropping in valves that have no leak, and what's going to happen to those, hard to know even as those dynamics change. But especially with transcatheter, it's likely there's the big resurgence we see of replacement may dominate over repair in any fashion.
Well, the difference now is that, this is a lot less invasive because it's transseptal, so it's a lot less invasive than our current transcatheter mitral valve replacement, or most of them. Just a quick question. Do you think you can reliably place your first and last screws in a little kind of closer position of a C shape so that you can use the ring for future valve in ring when it fails, if needed?
So, as I touched on very
I want
briefly.
you to set her up for her
Yeah,
next
I was going to
procedure,
say, Myra's ready for the talk, but as I touched on, one of the hardest parts was getting the first screw down. The truth is, the last screw is going to go where it's going to go because if you run in the right place, you don't have any control where the last screw goes. It leads you right to it. It's all about putting the first screw down. And yeah, you can get that in the right place and it lays itself out.
Good. Quick question, quick answer.
Do you see this procedure being done in combination with mitral clip or as a standalone therapy?
So that's the famous Valtech toolbox. I see all these things being combined. I mean, you can go to cords to clip to band to everything else. You can put them all together and repair the heck out of it before you replace it.
It's going to be interesting because both these therapies, in theory, reduce the valve area, both clip and a Cardioband. So we'll have to see. And plus, they're two different companies, so they might not. It might be difficult in practice to perform a trial.
No,
like
but it's
that.
been actually been a lot of cases done case report of combining procedures,
Yeah.
and they have done Cardioband with mitral clip, multiple
They
cases,
have, yeah, in Europe.
and they're quite successful.
Right, and in Myra said too, I mean, this is sort of ridiculously not invasive whenever you stay out of the artery side.
Well, great
Thank
talk
you.
and great discussion. Thank you. Now it's my